Thank you everybody for joining us again for the fifth day on this webinar on COVID-19. Our speaker today is Dr. Zerihun Bunaye. Dr. Zerihun Bunaye is a staff intensivist at St. Louis University Hospital in St. Louis. He is certified in so many things, including the pulmonology as well as critical care, and he is certified in ECMO and many sophisticated high-end, actually critical care certifications to manage complex patients. He is an originally graduate from Gondar University, and I am not sure if he has practiced medicine in Ethiopia, but he can tell us about that. He is a well-regarded faculty member and very busy managing COVID-19 patients. Today, he's going to talk to us about safe mechanical ventilation, and he will also come back tomorrow to give us a little bit of the second version or the advanced version of mechanical ventilation. So I would expect today's presentation would be a little bit more broader. So Dr. Zerihun, please, the floor is yours. You can say a few things about yourself to introduce yourself more and do a better job. And we're looking forward to your presentation.
Hello, everyone. So again, my name is Zerihun. I graduated in the year 2000, and I worked in Ethio-American Hospital. First of all, thank you, Dr. Grimar, for the kind introduction. I worked in Ethio-American Hospital from 2000 to 2004. So when I was there was no ventilator, and the only thing we have was the anesthesia machines, but I worked around those quite a bit and didn't see any mechanical ventilation. And unfortunately also whenever I visited Ethiopia, I haven't seen the medical system, how the ventilator situation set up is. But I tried to ask people, my friends, including Dr. Tigis Baja, who gave me some idea about the situation in Ethiopia. So again, I will try to talk about this mechanical ventilation. It's a huge topic. And I will try to concise it, in 2 days. And the reason I called it safe mechanical ventilation is because mechanical ventilation could be injurious. Actually, if you are not careful, it will end up more times than not, injuring and causing suffering for the patient. So, if somebody wants to do mechanical ventilation, it needs to be done in a safe way. It is a double sword, as many calls it, because on one side it could help, on the other side it could injure. So always it's a risk-benefit ratio. So going forward, so I'll try to cover some physiology. So I think I'll have a little bit of physiology, pathophysiology of COVID-19, some clinical pattern presentations, and the rest will be on mechanical ventilations. So as you know, many of the ventilators we do in hospital setting are very easy ones, like post-op. Those are post-op patients, and those are very easy intubation in ways. But when you mechanically ventilate a sick lung, it's a different business. You have to have a different mindset. So you have to zoom into the patient's body and lung and try to understand what's going on before you dial in your setting, and or first thing before you intubate and put the patient on mechanical ventilations. So for example, a patient with ARDS, and COPD, and, they need a totally different mechanical settings. Understanding the desynchrony and all things are very important. So in general, ventilator setting should be based on the patient's physiologic findings and not based on rigid standard protocol. For example, EADG protocol is a very popular protocol, and we definitely use it for almost most of our patients. But every patient is different. Every lung is different. So unless you are you are able to adapt for the specific patient, again, the ventilator might be injurious. So different diseases, different types, different lung and different patients. So this is what we have seen actually in COVID-19 patients. So it's very wide variety of presentation. So if we see how any ventilator or positive pressure ventilation can cause multiple organ injuries and organ failures is whenever you have a higher pressure, first of all, it will injure the lungs. The epithelial cells of the alveoli are very thin, very sensitive. They are kind of permanent cells. So if they are damaged, they don't replace, another cell should be produced. So they are very sensitive. So, if you stretch the lung or the alveoli too much, that will cause injury. It doesn't need to be to the extent to cause pneumothorax, but little injuries accumulate. And, because we breathe so many times, you park someone on a ventilator, with a large tidal volume, and, you let him breathe 20, 30 times, and that happens over the day. So that injury slowly accumulate and will cause a lung damage. So typically what, the mistake we have done in the past is when we put patient on a ventilator, the goal we are setting was correcting the blood gases, like, look at the SAT, we are happy, but, we understood now that we are fooling ourselves, because by looking at saturations or anything like that, is we are treating our own mind, not the patient. So what the patient wants is that you give him a safe ventilation with as little force as possible, so that he can live with the lung you saved for him or you saved for her in a long term. So the goal is to save the lung for the long term, not to correct numbers or so. So we should avoid any kind of distension, over distension, and any kind of recurrent collapse. So whenever this happens, so it will lead to cytokine storm, and these cytokines will be released and injure other organs and cause multiple organ failure. That's how patients with ARDS die. And other organs like brain, can be affected. It will affect ICP. Cardiac function can be affected in both ways. It can help cardiac output. It can also make it worse. And kidney, liver. So it's very amazing. Like especially in COVID patients, you see some of the patients, the minute you put them on a ventilator, the kidneys will be, really sick, and the next day dialysis, when the liver starts to fail. So, you have to be really thoughtful when you put someone on a ventilator. So the problem with, again, ARDS, if you guys remember, one is a baby lung, because the lung volume is very small. As you can see on the top CT scan, it's very collapsed, edematous, and the part where it says B is the volume we have. So it's almost 1/3 of the lung. The rest is not available, especially the lower part. The A is not available. The C probably can be opened up by people, so we call it baby lung. And, if you give this lung the same tidal volume you give to a normal person, the part A and C are already damaged by the disease, and you'll end up damaging the part B. So the patient will be crippled, going on. So as you can see, also the other problem with ARDS is it's heterogeneous. So, because there are areas where it's consolidated, and there are areas where it's, it looks healthy. So whenever you increase tidal volume or pressure, the volume disproportionately will go to the area of normal lungs and will cause small injuries, and that's how this will end up crippling these patients. So the other problem with ARDS is it's very heavy lung. It's a stiff and heavy lung. It's a wet lung. So these are the problems. And when COVID-19 came, that's what we thought. So we thought that it's going to be ARDS, and that's how we're going to manage it like that. And some of them are like that, but what we have seen is different. And if you see the Surviving Sepsis campaign, this is an American society, and they were saying that we should follow the standard ARDS protocol. And what we have seen, what we are learning is patients present with a wide variety of presentation. And what was also striking is when the patients come initially, what we have seen is their lung compliance is almost normal. That means it's not heavy, it's not a wet lung. You see a little fluffy infiltrates, but the patients breathe fine. So that's unlike ARDS. And when you see the lung imagings, they look fairly healthy. So, many physicians say, this is, and the patients are fine, breathing. They are settings 80s, 70s, and they are talking to you, completing a sentence. They don't feel dyspneic. So it's kind of bizarre. So many physicians say this is something I've never seen anything, like this. So again, to see the difference, the typical ARDS lung is a wet and heavy lung. And it has got thick edematous lung interstitial tissue, very low compliance, a low volume or the baby lung. The main mechanism of hypoxia is high shunt function. But in COVID lung, what we have seen is it's not wet. The lung doesn't seem to be a problem in many of these patients. And relatively, the interstitial tissue is normal or thin to the most part, except few areas. And the lung compliance is preserved in most patients. And the lung volume is also preserved. So that's why the patient doesn't feel dyspneic. If they want to take a deep breath, they can get it because their lungs volume haven't decreased. So the mechanism for them seems to be a low VQ mismatch. This is by mistake, I said high shunt fraction, but it's a VQ mismatch issue. And the problem seems to be not on the lung side mainly, but on the vascular side. But as I said, there is a shift from initially they will present like this, but later on they will change their pattern to ARDS, typical ARDS pattern in some of the patients. And this maybe the reason like the mortality in China was really high once intubated compared to the late Italians. So this is the hypothesis. What I'm presenting is the hypothesis by one of the big figure in ventilator management, in lung compliance, PEEP, and so on. His name is Dr. Gattinoni. You can, you guys, Google his name, or probably you know him. He's very popular, and there is an upcoming article will be coming in journal. So this is the hypothesis he gave. So COVID pneumonia is a unique disease, so that's what we know. And even though they have, sometimes or most of the time they have qualified for Berlin definition of ARDS, but they don't act like that. The distinctive features are severe hypoxemia with normal compliance, whereas ARDS patients, they are severely hypoxemic, but they have also low compliance. So, this is a weird combination, and, we don't see that a lot. Like we see in diseases like, high altitude sickness and so on, but not in this one. Or for example, carbon monoxide poisoning could be like that. They will be hypoxic, but the lung compliance is good. So So this is more resembling high altitude and a pulmonary edema. Again, the patients are, very wide, variety of presentation. Somebody sitting like this, watching TV, just looking fine, his sat is in the 80, to someone here, again, progressing to the point maybe soon to be intubated, somebody intubated there, somebody prone, as you see, and the others are on ECMO. So you see all variety of patients. So it's a very impressive uniformity what you see. If you see work of breathing, some of them are very dyspneic when they come, some of them are just normally breathing. We call that silent hypoxemia. If you see their partial pressure of their carbon dioxide in their blood, some are hypercapnic, some are normocapnic, some are deeply hypocapnic. And they look fine, I mean, because they breathe deeply, but they don't feel dyspneic. And when you see their PCO2, you see that they are hyperventilating. If you see their pulmonary vasodilator response, some are very responsive, prone positioning, some are responsive, some not. So it's a very wide variety of presentation. If you see the CT scan pattern, you could see that, anywhere, from the first CT where, it's almost, very fluffy, few areas of infiltrates, to somehow in the middle more, and, the last one typically are this kind. So, there's all kinds of presentation on the imaging. The same for the chest X-ray if you see here. On presentation, the reason for such a wide variety, they say, one, it could be due to the severity of the infection itself and the host response, and also the physiological reserve and comorbidities. That could be one reason, the different variety of presentation. The other is the ventilatory responsiveness of the patient to hypoxemia. Whether that means whether they will be responsive to PEEP or not. And the other factor which was taught is the time elapsed between the onset of the disease and the observation in the hospital. Definitely genetics factor, the type of ACE subtype, the and other factors I mentioned, there definitely matters. So if you see the course of the disease, some of them present hyperacute, like they come really huffing and puffing. You have to really rush and intubate them. Some of them has an indolent course, and they start slow, and they do fine, and and end up improving and winning their oxygen. They will go home. Some are kind of biphasic, or what we call, they start slow, but they get step up and get worse. So typically, 3, 4, 5 days, they will be fine, and then they start, to creep up their oxygen. And unless you catch them quickly, they really, really crush on you. So again, this is Dr. Gattinoni's work, presented on European Society of Intensive Care Medicine. So the thought is probably there are two different kinds of these diseases. One is type L, which is the disease, in about 70 to 80% of the patients, where they come, hypoxemic, and their CT scan looks like this. And when you see their lung, it's low elastance or high compliance, low VQ mismatch, and they have low lung weight, it's normal lung weight. Or, if you use PEEP, it's not recruitable. So, because everything is L, as you can see, they call it type L. And on the other side, the type H kind is where they have a high elastance or low compliance, and their CT scan looks like this, and a very high, and their problem is a very high strength, and their lung weight is very high, heavier lung. And if you use PEEP, these are recruitable. So these are the two phenotypes taught. So again, their CT scan difference is, as you can see, so much difference, but these two patients' CT is so much different. But if you see their PF ratio, it's almost similar. One is 84, one is 95, those are in the severe range. Again, if you look at the lung character, the weight, the compliance, totally different. And, they were able to measure based on CT scan the lung weight. And, for example, this lung weight is about 1 kilogram. The other, the type H one, almost 3 kilogram. If the aerated area is the non-aerated area in the type L is about 8%, whereas on the non-aerated area on the type H is really significant, 54%. The total gas volume on the type L is 4 liter, which means it's kind of normal lung, whereas in the type H one it's a baby lung volume, or it's like 1400 ml. And the driving pressure on this one is almost normal on the type L, whereas it's high. The compliance it is better, whereas it's low on the other one. So again, here they were trying to show what they showed is the distribution of aerated and non-aerated region. The blue part is the aerated one, so there's more aerated regions based on the CT scan measurements on the type L. So type L responds to oxygen. So, when you treat them, so oxygen supplementation is the main mode. And, even after, if you end up intubating this patient, if you use a high PEEP, they will crash on you. So you have to use low PEEP. And you can sometimes, if you need to liberalize volume, it's kind of the lung is not that sick. So you can give them a higher tidal volume. Whereas if they come with a type H pattern, they need pressure more than the oxygen. So either they need CPAP, they need PEEP. That's the main mode of their treatment. So a high PEEP strategy is necessary, and a low tidal volume is also a must. So they are treated as a typical ARDS. So when they come with hypoxemia, again, the two subtypes, and the phenotype L, the mechanism is, the low VQ mismatch. And when they started to have, a high work of breathing, and the edema slowly develops in the lung, and they could transition to the other types. So they need to be carefully watched. So how do we differentiate between the two, subtypes? CT scan is the best way to differentiate, but obviously CT scan probably is not applicable in these patients due to aerosolization, infection risk, and so on. So I think what we can do clinically at the bedside is, we study the lung mechanics. If the lung mechanics is bad, then it is the typical ARDS. If the lung mechanics is still reasonably okay, then it's type L. So we assess the respiratory system compliance, and the formula is, we calculate tidal volume over driving pressure, or tidal, the driving pressure is plateau pressure minus PEEP, and the recruitability is the other thing we look at, which means as we increase the PEEP, if the driving pressure decreases, or if the compliance improves, or if the oxygenation significantly improves, that means the PEEP is opening some alveoli and effectively improving the mechanics and the gas exchange. So that's another way to differentiate. So if the lung is recruitable, it's type H. If the lung is not recruitable, if you don't see any much difference, probably, or worsening, and that's type L. In general, to say COVID-19 pneumonia is not necessarily equal to ARDS. So we have to have that understanding. So this will really, is the base of our ventilator management. So we treat those two. If those two kinds of patients, we have them on a ventilator, we will manage them totally differently. So, for example, the type L patients, if they become to our unit being not dyspneic, then we'll give them oxygen, and we will assess their work of breathing regularly. Because of their hypoxemia, they tend to breathe deeply, but they don't feel that dyspneic feeling, because they are able to get whatever they want. Their lung volume is okay. So, but they will generate a very huge negative pressure in the pleura. So, which means they will stretch out their alveoli, and when that process goes on for a long time, there will be a leak into the alveoli, and the edema slowly develops. So whenever you see excessively high work of breathing, you can see that the patient probably will be transitioning soon to the type H or the edematous type. So it's good to intubate these patients earlier. If they come with mild dyspnea, you can put them on high flow nasal cannula or CPAP or non-invasive ventilation. And one thing that's seen is non-invasive positive pressure ventilation has a high failure rate, and also is known to cause delayed intubation. So in general, if you intubate, early intubation is what is recommended. So different kinds of oxygen supporting systems here. So one of the first thing we have to do is we'll try to assess shunt fraction. So this is important because it can give us an idea what kind of lung or problem we are facing. So if you give 100% non-rebreather oxygen, as you can see on this patient, and the patient oxygen saturation is not getting high or not changing much or not getting to the goal wherever you say it, in this case 94, then probably that's a shunt mechanism, because shunt wouldn't get improved by FiO2 significantly. If the SAT improves significantly to greater than 94, probably the mechanism is VQ mismatch. So and probably it's type L. Shunt is ARDS because those collapsed region, the blood that goes there doesn't get oxygenated. So again, this is the shunt mechanism to demonstrate here. So the severe shunt one, the yellow line there, even though the FiO2 is increased from 30% to 100%, the shunt fraction only shunt fraction only moved significantly, so 30 to 50, whereas in the mild case the change is very little. So the next thing we have to do is again assess their work of breathing, so their respiratory drive, and this can be affected by the disease itself or the metabolic state, or the hypoxemia, the neurotropism, pulmonary edema. So these are deeper stuff, so I'll pass it for now. But again, you treat them with either high flow nasal cannula or non-invasive ventilation or CPAP, or if all this fails and you have to intubate them, preferably intubating electively. So one note to make is non-invasive positive pressure ventilation is aerosol generating, and there's a high failure rate and can exacerbate the PSPCL, which means patient patient self-inflicted lung injury. Whenever a patient breathes very deeply or kind of excessive work of breathing, they can cause a lung injury themselves. So you have to intubate them and rest them so that they don't injure their lung. So and non-invasive positive pressure ventilation has a tendency to worsen that. And some consideration like infection control, resource and so on should be done about these treatments. Again, I'll pass this one. So criteria for intubation. So again, before you intubate, the pandemic medicine principle is, health workers' safety first before the patient. So you have to really have a good protection. You can see me, I was ready at this time to intubate a patient. And this is the Chinese protocol I found in the article they published. And whenever there is a call for intubation, if the reason is like cardiac arrest or airway issue, then they will immediately, urgently intubate. And if not, they look at the the work of breathing and the oxygenation. If the work of breathing, what I meant is if the respiratory rate is greater than 30, or if they see the patient, using accessory muscle a whole lot, then, you may have a trial of non-invasive or positive pressure ventilation for 1 to 2 hours. That's it. And if the patient improves with that, it's good, you may continue, but if not, you gotta intubate. It's not like, you park them on CPAP and you go away. So, and, you have to watch them and intubate them in the next hour or so. If the hypoxemia is below whatever the set goal, for example, for, if you say 90%, then, if that is unachievable, then again, you can try the CPAP non-invasive for an hour or two. If that fails, you have to go straight to intubation. Again, intubation, it needs a detailed preparation, and this has been presented in the other presentation, but this has to be really taught, well planned. As you can see, they have a map, they have a list, they have all kinds of preparation, and it's like whenever you are called intubation ready. So, I encourage Ethiopian community to do such preparation ahead of time. So again, about the intubation, this is about the timing and other details. So I'll pass those one. Again, patient self-inflicted injury, spontaneous breathing is not always good, and it can injure, and it can transition the patient from the type L to the type H. So before they injure their lungs and make it something prone to fibrosis, we have to intubate them, we have to sedate and paralyze them so that we reduce and prevent these kinds of injury. So again, the type L disease, some of them they will improve, some of them they get worse, and slowly develop that edema, and then their lung volume gets smaller and smaller, and becomes typical ARDS. And the change to this typical ARDS pattern could be due to the patient himself, their work of breathing causing the edema, or the inflammation. So, either one, so the treatment is the same, but the mechanism could be the patient himself or the disease process. So again, this is a flow chart. This is, I think, the UK practice, how they go through the patients stage by stage. So I will discuss this. So can I get 5 minutes and then I'll stop, and Dr. Guma?
Yes, you can have 5 more minutes, sure.
Okay. In the UK, experience, so this is what they do. So they start with oxygen therapy once the patient is greater than 40%, which is about 5 to 6 liter oxygen. Then they start to look at the work of breathing. If the work of breathing is high, then they go ahead and intubate. If the work of breathing is low, they can give a trial of non-invasive ventilation like CPAP. And the next thing they do is, if the CPAP fails or the work of breathing is high, then they intubate. They put the patients on, tidal volume of 8 ml per kg predicted body weight. They use PEEP of 8. Respiratory rate, typically, anywhere between 10 to 20, and they try to get the PSO2 to a normal range. And they set a goal of, their SAT goal is 90 to 94, and the plateau pressure less than 20. At this point, when the patient is intubated and placed on these kinds of setting, they see the driving pressure. Again, driving pressure, as I said, it is plateau pressure minus PEEP. So this has to be less than 15. So the driving pressure is what generates the tidal volume. So the pressure in the lung won't get below the PEEP. So whenever tidal volume is inflated, so it will go to the plateau pressure. So as that is increased to a higher level, that means for every centimeter of water pressure, the volume will get less and less. So that's a bad sign. So if that is high, then we need to go ahead and decrease the tidal volume to like 6 ml per kg. If that is good, or less than 15, then we keep it as it is. We don't change the volume. So after this, then we need to optimize the patient. So if the patient is starting 90% and requiring such a high FR to like 70%, then the patient needs, we need to decrease the oxygen demand by using like neuromuscular blockade and deep sedation. And at this point, we start using PEEP. And the way they do it is they increase the PEEP by 2, and in measuring the effect, and they slowly go up to like can go up to like 15. And then again, they keep the same goal: driving pressure less than 15 and plateau less than 13. So if by increasing the PEEP, if any of this is violated, that means it's time to stop. We can't push it anymore. So once they did that, then they calculate the compliance. Compliance means tidal volume over driving pressure. If that is greater than 40, then that is the type L pattern. And if it is less than 40, that is the type H, or the typical ARDS pattern. So if the lung compliance is greater than 40, which means a compliant lung, then usually the first strategy after this they do is prone positioning. So all this time is the patient is requiring so much FiO2, that's they're trying to address that. So prone will be here, and less PEEP still will be the goal. So if the compliance is less than 40, then the main thing they do is, they use the PEEP FiO2 table of ARDSNet, and they do sometimes recruitment maneuvers. So because these are recruitable lungs. So, they will go like that. And if all this fails, they call for ECMO and assess for that. So I think in general, in summary, if they are hyperacute, intubate and immediately intubate. If you want to use CPAP, it has to be only for a short time. And, you have to try to differentiate, the types, L phenotype L2 from phenotype H. As I said, you start from, say, the shunt test, you just increase their FiO2 and see how much they respond to that. If they don't respond, then that means it's a shunt or phenotype H mechanism. And the next thing is, you look at the lung mechanics, recruitability and the compliance. So that can tell you what kind of patient you are seeing, and you can decide the kind of ventilator setting you want for these patients. So I think one thing probably I would say is, I don't know what kind of ventilator there are in Ethiopia. You have to be careful. It has to have 2 limbs, like the lowest one. The one limb ventilator circuit, their exhalation port is, just exhale, the air is getting out to the air. So I don't know, because I have seen reports of, some areas where they're using wrongly that kind of ventilator. So it has to have dual limb. That means the exhalation, the exhaled air should always be go back to the ventilator and filtered. And I have seen people asking question about ventilator dividing for 2 patients. I really strongly advise against it, and many reasons for it, but I'll keep that for now, and I'll take some questions.
So could you go back to the ventilator split picture right there? I think stay on it, because one of the questions is, with shortage of ventilators, that's significant back home, that might be one of the next steps you have to think about. Can we use in this situation of scarcity, splitting ventilators? Can you just elaborate a little bit how that is done, if it needs to be done?
So, ventilator splitting, in this case, if you want to do it in a safe way, you need a lot of things. As you can see there are multiple valves, flow controllers, multiple filters, and, tubings. So, it's complex. So I think, the one, many people talking about is, you have to find the kind of patient who is having similar, lung compliance, and you can put them, in a similar setting. They have the same infection, COVID, and the same compliance. So you can use the ventilator on them, but that's wrong because one, compliance is not a static issue. It changes over time. So again, the reason you put them on a ventilator is to let them survive with as little gas as possible while you are protecting the lung. So if you give a tidal volume and it goes to the more compliant side of one patient, then you are injuring this patient. You just can't know it. You can't monitor the pressure between the two. So, the way the model it was presented is wrong. So, over the course of the time, patients go to a different way, and disconnection is another problem. So you may want that one patient to do or to transport them somewhere. That complicates a lot of things. So actually, the Society of Critical Care Medicine recently gave out a very strong argument, against this, and I can send you that article if you guys are interested to read more about it. So I don't recommend it.
So so here is, I know Dr. Theodros is also on the line. Dr. Theodros, you want to add a couple of things before I start opening for more questions that I have a long list. You want to say a few things about what has been so far communicated?
Thank you, Dr. Girma and Dr. Zerwin for the excellent presentation. It's good to know that there are different phenotypes, but I have a question to Dr. Zerwin that I have also sent it via the chat. And my question is that the L type, do their POO2 to FiO2 ratio less than 300 to fulfill the criteria of ARDS according to the Berlin case definition? And when I see their image, it looks like that it is in the early spectrum of the disease, and later on they progress to H, where that is probably the RDS that we call, or that fulfills the criteria. So can you comment on that? And the other is, what what mode of ventilation do you prefer? Is it pressure controlled or volume controlled, and why, with regard to their outcome? And I heard that the outcome of ARDS in this group of patient COVID-19 is said to be very bad once they are intubated. Can you tell us the reason? Thank you. That was really excellent presentation.
Thank you. So I think if you see, the two CT scans I showed on the presentation, interestingly, their PF ratio is similar. One lung is really heavily white. One lung is, typical dark, air-filled lung. And the PF ratio is the same. The ARDS, Berlin definition, if you remember, you need, bilateral infiltrates, and you need at least PPO5, and the PF ratio is less than less than 300. But even though the type L1 qualifies for that, the lung mechanics doesn't go with it because the compliance is not, is almost normal. So, and that goes against the ARDS definition. So even though their PF ratio is similar, so the thought is the type H is the issue is the main issue is the lung being edematous, atelectatic, and heavy lung and difficult to open. Whereas on the type L1, the pathogenesis is thought to be, it's a vascular issue. So there is a very high perfusion, or there is dysregulation of the pulmonary vasculature, and there are areas really massively hyperperfused, more than what the alveoli in those areas can supply. So that is a VQ mismatch. So and if proning helps these patients, is not because of the redistribution of the lung edema, it's probably the redistribution of the blood in those areas. So the mechanisms is different. The way the mechanics of the lung is also different. So even though they have same PF ratio, look like both seem to qualify for the Berlin definition criteria. I think that's my answer. If I answered the next question was, if I remember, on
volume control versus pressure.
Yeah.
Control.
So I think the mode what we should probably use is a volume control mode. The reason is I think this is the most studied mode. If you see all the artesunate trial, is done under assist control volume mode, which is a mode where there is a set rate, there is a tidal volume. So and the ventilator will give the same volume every time, and that is initiated by either the ventilator or the patient. So if the patient tries to initiate a breathing, it will give 500 ml. If the ventilator, when the time comes, gives the same. So assist control, volume assist control is the mode, and that's what we studied, and it guarantees volume. And especially in Ethiopian setting where alarm and so on is probably, I imagine, I think when physicians are not there, the nurses may not understand what it is. I would say that's a safe mode, and that's the mode I think everyone probably is using. So I say the mode you have to use is a volume assist control. And sorry, remind me the third question. I have to write that.
Yeah, so thank you both for the comment and the questions. So first of all, I just want to say to the audience that the Ethio-American Doctors Group has a website and a Facebook. Just please visit that as well, because all these presentations are going to be actually posted to be available in the future for for those who did not attend, or for those who want to listen to this again. So with that, if Elias, do you have any additional comments on the issues that were raised right now?
Yeah, Gurma, couple things. Thank you. It was a nice presentation. So a couple things is, I know there's a split ventilation is sexy, but it's very dangerous, as the doctors have said. I think what we should do, especially in the Ethiopian condition, is number one, avoid intubation wherever possible. That's the best way you can actually maintain your vents, right? Because mechanical ventilation is in general is associated with high mortality, right? Especially in low and middle income countries, for a lot of reasons, right? Because number one, we don't have the equipment. We have a different kind of equipment. We don't have the tubing. We use the single-use tubing multiple times. Cleaning is hard, which is more important, especially in the COVID era, where infection. control is an issue. So, and of course, there is no training, human resources, trained technician that run the vents are a very limited resource, right? So I think, so we avoid intubation as if possible is the number one thing to do. Of course, you have to talk, we discuss about goal of care discussion with family ahead of time. And if you have to intubate, expedite weaning. So you can use your limited resource adequately. I think we should focus on those things more than talking about splitting the vent, which I don't have any experience on. It's a very dangerous procedure to do for reasons Dr. Zariun mentioned. And those are my comments.
Thank you. So I think there are a few questions that are definitely repetitive. Number one, Dr. Elias just mentioned about quick weaning, but there was a question from the audience if the weaning protocol is any different from other respiratory failure patients. Would you be more cautious in these patients that you don't want to take a risk of re-intubation because you re-expose everybody? Or is the weaning protocol the same like in any other intubated, medical, pulmonary issue? How do you practice?
So the weaning protocol per se is not, different, but, typically these patients require the ventilator for a quite long time. They, 2 to 3 weeks is a common duration of mechanical, ventilation. So, you have to be patient, don't just, manipulate, every now and then vent, or you need to give them. There's a lot of inflammation on them. And, we don't have any proven medication. All you are doing is just having them survive with as little gas or as little oxygen as possible without injuring the lung and just waiting. So that's all we're doing. So I think we have to be patient. We have to give time, and, we have to set that mindset, from the get-go for the family, for the, for the staff and so on. This is not something, quick. It may happen, but usually not the case. So once, things got better and the inflammation settles, you follow the CRP and, all other markers, and the oxygen requirement is down, the patient is waking up and so on, then, the typical weaning protocol, doing, awakening and then spontaneous breathing trial. So there is nothing really different about that. But you gotta be patient. It needs time for these patients to heal.
So one specific area that is also being asked here is, you mentioned it in passing. I think the airway manipulation is also the time when basically you expose the healthcare workers to the problem, right? So that's the highest risk of getting infected and all that. So with that being, the baseline understanding, there are places where they have teams like airway strike teams. So there is a set number of people that are, experts in airway management and are there on call in shifts, waiting to do this intubation in a very, highly efficient way and with minimal risk for other health workers from being contaminated. So, Dr. Zariun, do you have an airway strike team like that in your ICU?
Oh my God, and I can't tell you enough how much time we spent preparing for this. And every day still we are improving things, and we are writing them. We are, putting pictures. We have, things at the, next to my office. There will be gloves and gown and so on, so that I could, put those on the way. The intubation kits are all in place, color coded, so that I don't have to think much about it. And there is a lot of preparation, and we have done a lot of dummy training. Right now, because the numbers are increasing, we were intubating, ourselves, we are kind of, giving those things, from, for example, lines and so on. We gave a line team, the surgeons are doing that for us. God bless them. And now we are on the process of giving out the intubation for anesthesia so that, we can focus on, I think now we probably soon will be giving also the ICUs to other, doctors, and will be, just kind of, overseeing them. So it is very important, I think, to sit down and work on all of these things, like donning and doffing. You gotta practice it. You will miss it. So you gotta practice it, and as if your life depends on it. You gotta look in the details. And it's very important doing, all those things. And you have to, every time before you go into the patient to intubate, you have to talk and, just make sure everything, is going how you communicate, because you will be all covered. You may not listen each other. How you communicate, sometimes we use these signs, I want this, I don't want this. So it needs a detailed preparation, and it has to be taught well ahead. And every time we go out from that room intubation, again, we take a note. And there will be one person actually watching me when I'm donning, to make sure I'm doing right. And when I'm doffing, taking out also the same thing. So, we take time on this. Healthcare workers are irreplaceable. So we should do that.
So Dr. Tedros, you have one more question for Zarihun?
My question is on the Zarihun, you showed us one of the last slide was UK guideline. In that guideline, don't you think that we know that, and from the lecture you gave us, prone positioning is one of the effective way of managing at least half of this group of patients. So don't you think that it should come earlier than the neuromuscular blockade or other interventions?
So, proning can be done, anytime. I think if you want to prone, you got to prone early. Don't wait late. But, I think if you have to see the response for proning. So, for example, in us, we'll get a blood gas drawn, and we'll see that if the PF ratio has improved. If the PF ratio hasn't improved, we'll supine him, right away. There's no reasons to keep them, prone. So, it may be beneficial in some, it may not be. So as I said, the mechanism, it helps the RDS is it redistributes the fluid around and, improve the VQ mismatch. So, for some it will be good, for some it don't work. And, I agree on initiating early as possible. So, you can go either way. Typically, once, patients are kind of progressing and requiring still FiO2, all these things come all together, paralysis and, proning, heavy sedation, all will come together.
So I know from some of the presenter online, I don't see you, I don't see everybody on my screen here, a very small screen. So I don't know if Rahel is there, Mola, Dawood, if you guys have any additional comments, please go ahead.
Hi, it's Rahel here. How are you?
Good morning.
Good afternoon, everybody. So there's a couple of comments definitely about the intubation. I think yesterday somebody was asking when we're going in and intubating. I think every institution, every location is going to have to come up with their own decision and protocol for how they want to handle things. And it's going to be, a lot of things are going to go into play, such as resources, for example, right? The things that I'm doing in my institution may not very well be the exact same things that are happening in St. Louis, and may not be applicable for the situation or resources that are in ADIS. And so understanding some of the limits placed on resources, I think lend itself to answering this question about this early proning and doing things like that. I know some places will send patients home and tell them just, you know, at home, lay on your stomach, stay in this prone position as much as you can if it brings you relief, in order to minimize you know, the use of anticipated scarce resources in the future. So I just wanted to say, we're giving you all this information, but it has to be customized for the setting of where these patients are coming and what is available to help. And then something that will also always protect your healthcare workers and do the best you can for patients. And that's it.
Gurma Elias, can I say a couple of things?
Sure.
So, well, a couple of things. I think important to understand is you have to have a protocol, like Dr. Helen says, about when to intubate. So, because remember, these patients do tolerate, as Dr. Zaru mentioned, the silent hypoxemia. They do tolerate low oxygen content for some. So, I think it's very important to have a protocol. So what I was saying is, I think you should have a protocol. I was mentioning my facility has a protocol. We are willing to tolerate as low as 87% of oxygen saturation on a pulse oximetry, as long as the patient's hemodynamics are stable. So, and that will help you avoid intubation. So I think I think it's very important to have a facility-specific protocol and communicate it with nursing staff and the ICU nurses that manage the ventilators, or if you have respiratory therapists, with them as well. And everybody has to be on the same page to avoid, number one, multiple calls, as well as they are easy with your decisions. So that's very, very important, I think.
No, thank you. So I think we are going to conclude today's with one question, which is really more an ethical question as well. And I don't think there is a very straightforward answer to this. And one of our audiences is saying, hey, we have really a shortage of all this mechanical ventilation. Plus, we see the outcomes of patients who go in mechanical ventilation is poor anyways. And so, you know, why not we just decide on not getting there? In other words, would it be better if we just do the other management packages and avoid intubation and hope for the best? So this is really more an ethical dilemma and a resource dilemma as well. And I'm sure these are questions that needs to be answered, you know, depending on the local situations. But maybe Dawood can weigh on this, and everybody can chip on this issue.
Yes, I heard the question, and I said I don't have the liberty to comment on this. The pulmonary and the critical care teams also have to chip in. But as a general rule, as I have been following this COVID issue for a long time, I just want to say this for Ethiopian perspective. We're working very hard to really standardize the issues before ventilation. We're trying to come up with a standard guidelines on to who needs to be admitted, who needs oxygen, when can you stay on nasal cannula, face mask, and then non-rebreather as a stage to prevent ventilation. Because as you can see, those areas we can work and upscale our hospitals capacity in a very short period of time. We're looking very closely at where we can find oxygen concentrators and how much they cost, how we can actually supplement the Ethiopian hospitals. I mean, when I say we, there is a task force here, Girma, you're part of it also, who's advising the ambassador. There are a lot of organizations who are collecting money here in this country. From what I'm hearing, it has passed already $2 million collection. And they're also asking about what kind of supplement to give. They give away, the easy answer is PPE, of course, and we are not going to compromise that as long as we get the access to PPEs, because of protecting our healthcare workers will be paramount and critical. But the second thing that we're looking is how can we actually supplement oxygen concentrators, non-rebreathe masks, nasal cannula, face masks, and oxygen support in the hospital. So this is something that the Ministry of Health also is looking very closely. I mean, that is what I can say, because it's very difficult to upscale ventilator settings in hospitals, because after all, you also need the intensivists to manage those ventilators. Thank you.
All right, thank you, Daud. So I think just to be respectful about time, what I will do is I will keep some of the questions from today that were not answered and bring them back tomorrow, because Dr. Zerihun is going to give us the part 2 of his presentation tomorrow. Probably between today and tomorrow, there might be some new data that comes out and change a lot of things as well, as this has been a very moving, it has been a moving target, if you will. And so with that, I really want to thank you all for logging in and listening. Please go to Ethio-American Doctors Group website and also follow us on Twitter, because we do put some of these videos on Twitter as well, and type in Ethio-American Doctors Group and you'll see it. Otherwise, the slides will be sent to you so that you can have them. And it's really very nice to see a good amount of people participating from Ethiopia. Actually, today we hit over 120, so that's really nice to see. And again, for the presenter, Zerihun, amazing job. Thank you so much, and looking forward to part B tomorrow. So everyone have a great day. Thank you.